You ready? Or do you need? Okay. I started to say good afternoon, but I think it's good morning still. And I will officially open this meeting of the Public Health Committee of the House. So we are officially underway, and with that, I will turn over the mic to Senator Hufstetler, and he will bring us Senate Bill 446.
46.
And what LC are you working on, Senator?
Let me pull that back. There's actually only been one. It didn't have any changes.
Oh, okay, we got it then.
Yeah.
339362S. Everybody got a copy?
Yeah.
Okay, everybody's copying. But before you get out of here, when I let you go, thank you so much for being on time and for helping us to get a quorum. We're going to need to do this probably frequently in the next couple of weeks, since the rule chairman has told us to get things out and not at the last minute, or they won't be heard until next year. So we will be meeting at different times. So watch your emails from Lynn. Okay, Senator, we're ready to go.
Thank you, Madam Chair, and it's great to be here. And we've got the same urgency from Ways and Means. I got a large number of bills. We'll just say that, and we got 4 of them passed out as word for word yesterday. That came over to my Finance Committee. But I'm here because syphilis has made a big comeback. You know, when I was a child, and I'm an old guy, bacterias were the things that we had to worry about, and then came the viruses, and then syphilis kind of went away to the point they really weren't even talking about it in medical school for a while, and then the last decade it's really come back. And if it's not treated in the womb, it can have irreversible effects. In some areas, up to 40% of them don't survive. The long bones don't form, severe anemia, brain and nerve problems, blindness and deafness, enlarged spleen and liver, a lot of issues there, and they're going to be wards of the state. While we've been looking at this with alarm, and I had this bill ready, when I was getting ready to present it to our own health care committee a couple of days before that, this article came out that I gave you that showed that Mississippi had seen a 900% rise in number of infants that were born with congenital syphilis. So what this bill does is it sets up, and many people are testing, and of course, you know, this is a blood test that's done, and because we're working on pregnant women and their newborns and infant mortality and morbidity here, and this is entirely preventable. The testing is cheap. The common, inexpensive antibiotic is effective, though contrary to common belief, sometimes it does take multiple doses to get rid of this. And it's here supported by the Department of Public Health. The Georgia Hospital Association helped me clarify the language in the bill. It requires testing at their first prenatal visit from the healthcare provider at 28 to 32 weeks and at birth. And many, as I said, are doing this now, but we have seen a large increase in the state of Georgia, and Mississippi's seen an even larger increase than we have, but we've multiplied it, and it's getting out of control. And I think this testing reinforcement at those levels will help bring this down and let it be treated while they're still in the womb before it's too late to fix any of this. That's the bill. I'm hoping the chair of this committee will carry it because she's long been a champion of these issues. And with that, I'll certainly yield for any questions.
I'll be glad to carry it for you. Certainly, and on my committee, I've got a great committee. We're all concerned that we try to get newborns here as healthy as we possibly can. I think that if they pick up HIV, I'm not sure about syphilis, but if they pick up HIV early on in a pregnancy, there's about a 20% or higher possibility, that they will, less than 80% of them can have treatment and will not suffer the consequences of being HIV positive if we pick it up early in the first trimester. So it's really important. I do have one question, and I'll turn it over to the committee. It seems like to me that a few years ago, we passed something about testing when they come into the hospital. And
we do have testing in place. I don't think it's quite as thorough as this. And this is also any healthcare provider. It may not be a doctor they're going to, but whatever healthcare provider they're going to, And again, when you take, as Dr. Al knows in anesthesia with me, you take a cc of blood, you can get 100 things out of that cc of blood. This is just another thing to make sure that they are testing for.
I think it allows for testing when they come into the hospital if they haven't been tested before, just to make sure that they are negative. Because during delivery, I think it puts the healthcare workers, at risk if they're not tested, and if they're positive, let them put precautions in place. And even if they just find it then, if they are treated, at least it helps the infant going forward after birth.
Absolutely.
Who's number 28? Representative Fleming.
Thank you, Madam Chair. Senator, I was looking through the bill. Actually, my attorney, Representative Silcox, was looking through the bill trying to explain to me the difference. And what we concluded was there's already a requirement for this testing. We're simply making it at the first appointment is what it looks like to me. That's really what the bill does, right?
We're expanding the testing to include the first appointment, 28 to 32 weeks, and at birth. This is, and of course the mom is tested too, as the chair said. But this is a little bit more rigorous because we're losing right now. We thought it was almost like polio. We thought it had gone away maybe 20 years ago, I think.
So the summary of the change, if I may, is that we did require at birth. Now we're going to require at the first visit.
First visit, correct.
Okay. Thank you.
Right.
Thank you, Madam
Just like
Chair.
that. Well, I think it was actually, we required it as soon as the person, presented themselves. And it could have been not just at the hospital, but that's where it was usually, is that they would get to the delivery process and not have been tested. So that's where we were trying to catch people. But this is a much better way of going about it, doing it early, getting them to do it. Okay, Representative Perkle.
Thank you, Madam Chair. And to piggyback on my learned lawyer friend who can read this better than I can, but it appears to me, and perhaps I'm wrong, I think the language that we have now with your bill appears to be perhaps clearer and certainly more concise. But it looks like that we're going to be doing the same thing we're doing already. First, third, and delivery. But now it's spelled out in just 3 lines versus 25.
Well, I think those involved in this in the Department of Public Health didn't feel like we were capturing everything we should, and that this bill would better capture it. I worked with both the Department of Public Health and the Georgia Hospital Association getting the language that they thought would be most effective.
Okay.
Representative Perkle, you still perplexed?
I mean, if they think this is more effective, but in reading it looks like we're doing the same thing in a more efficient wording. I don't know. Maybe I'm reading it wrong, but it says every shall. That assumes responsibility shall be required to test, and then additionally the 3rd trimester, and then at the delivery. But I agree that it seems clearer with the language you have here.
Well, I think maybe that one of the things that wasn't clear last time, a huge number of women that were not being tested that were getting prenatal care and early on at the first visit, it was assumed that middle class, often white women really didn't need to be tested, that they weren't likely to be HIV positive. And as we now know, HIV is through all segments of our population. It doesn't matter whether you're white, black, pink, purple, whatever, it's out there, or what your nationality is, old in our older population. And so I think maybe a lot of the OBGYNs were perhaps not doing this, or not talking to the mothers that they needed this, and being positive about more positive. There's a way you can say it, do you want to opt out of this, or whether we need to check you to make sure that, you know, you're clear and this is one of the tests, that whether it's a way of handling it. So I think that this is one of the reasons, okay? We have somebody who would like to speak on it too from Public Health.
Hey everyone, Megan Andrews, Assistant Commissioner for Policy at DPH. I think I can clarify what you're asking about. If you look at the crossed out language on lines 34 through 38, there's an exception to testing at delivery if the woman doesn't disclose any high-risk activities. A test at delivery is not required. This came up, we were updating our regulations regarding prenatal testing requirements last summer, I believe, and came across this language, which is out of line with the standard of care as far as prenatal testing, because Georgia is a high burden syphilis state. So testing at delivery for every pregnant woman is indicated in Georgia. So that caveat that was in existing law kind of gave an option to providers for not providing testing. We also had a lot of conversations with the hospitals and MAG, and they had some concerns about women not feeling comfortable in a delivery setting disclosing some of their activities that may be high risk because of judgment from their provider or anything of that nature, just not wanting to disclose it. So this kind of closes that hole.
Okay, go ahead.
But they can still opt out if they
Yes.
chose to.
Yes.
Okay, thank you.
Yeah, that's all. But earlier is best. Representative Reese.
I think that conversation with my colleague over there kind of answered everybody's questions, but I was more concerned about line 14. Well, not really concerned. I just wanted clarity, except in cases where the pregnant woman refused the testing. So when you lead with that, to me, a pregnant mother, it sounds to me, can opt out at any level, right?
They can.
So there's no point in this bill where testing is absolutely mandatory.
Right.
And what does the procedure look like for opting out? Do they have to sign some type of document, or is it just as simple as saying no to the provider? I do not want to be tested for that.
It's a conversation between the patient and the provider.
Right.
Our hope is the provider will provide some education to the patient on the potential risks of not getting the test done to their baby. But there's not any sort of like documentation the state requires for anyone opting out.
Thank you. And Senator, I really like this bill. I'm glad that you brought it. I think that, looking at it particularly from the African-American community, if we would take more advantage of blood that we do take, even in regular hospital visits, you get enough blood to test for a lot of things that run rampant in our community. So I think this is a start, but I would certainly like us to see us take more advantage of opportunities in a healthcare setting where we've already collected the blood and just simply need to do the test. We're discarding a lot of blood, and we could be helping our community.
And 2/3 of these children that are born with this are African-American
Right.
and end up being a very bad life that are wards of the state, and that's what we're trying to not let happen.
At the appropriate time, Madam Chair.
Okay, at the perfect time. Okay, Representative Lott. No, you waved. She answered your question. It was the appropriate time. Right. Well, and there's nothing to keep, if it's discussed at the first visit and a mother doesn't want to opt in at that time and wants to think about it, there's no place in here that we keep on a second or third visit for them to go ahead, before that 32, whatever the mark is, in getting the test. Sooner's better on treatment. So, but anywhere along this cycle, if they will opt in, if they turn out positive, being treated is a huge positive, and trying to make sure these children are not marked for life with various disabilities. Okay, Anelowitz.
Yes, when this option is being presented to the mother, is there any discussion about, this is a test, it's very standard, it's very routine, and it can determine things that could help your unborn child? Is that,
That's
is there basically would the mother be fully understanding that if she does opt out, there could be
Yeah.
a risk to the child?
I certainly hope so. Every health provider is different.
Right.
They didn't put another form, more bureaucracy in there.
No, I know.
But these people ought to be aware now of the multiple 100% increase we've seen in this, and will be helping to tell them you can opt out, but we don't do anything else other than just test the blood we've already taken, and hopefully they'll educate them on the importance of it. But we didn't want to create a bunch of bureaucracy.
No, I don't disagree with that. Thank you.
Representative Seabaugh.
Thank you. And Senator, thank you for bringing this bill. I think it's important. I think we're trying to save these children as much as we're trying to heal the mothers. I think it's a great bill. My question is, if the mother does opt out, it would be documented in the medical record, correct?
If I was a healthcare provider, I would document that.
Yeah,
Right.
I think that's important when you start doing your statistics, that you know how many women opted out and then had issues down the road, or their babies had issues down the road.
Right.
Great, thank you.
Right, yeah, and Kathleen, could you go to can you speak? I want to ask you a question. Our expert on a lot of these diseases. Okay, tell us who you are.
Kathleen Tehan, Georgia AIDS Coalition.
Okay, when somebody tests positive for HIV positive, is there a procedure for reporting that so that there could be follow-up, or?
Yes, there is.
I'm asking, so
There
what is that procedure? You need help? Okay,
Go ahead.
all right, everybody, what, is there, Representative Perkle, you have a? Okay, because if a mother is found HIV positive, okay, what is the?
So, HIV tests are a notifiable condition in Georgia, which means they're reported to the Department of Public Health to take further follow-up on. We usually get them from either direct reports from a physician or electronic lab records that are automatically fed into our system. Those cases that we receive do get contacted by our office for assistance with referrals and linkage to care to get them into treatment and reduce their viral load, so they are unable to transmit it at that point.
So one way or the other, they are following up on these cases, and, you know, if a mother has refused care, trying to, you know, or they make sure that they do hopefully come to care and understand why they need it. So, okay, is there anybody else? And I'm sorry, Kathleen, I thought you would know the follow-up. She's better. Is there anybody else in the audience that, okay, let's posture. What's the committee's posture on this? And Representative Reese? Time.
Senate Bill 46 LC 339362S SCS, I recommend that this committee do pass.
Okay. Got a pass and second. Is there any further discussion from the committee? No. Is there anybody in the audience that wants to speak to the bill? No. Seeing none, then it is time for a vote. Everybody in favor of the passage of Senate Bill 46, say aye. Aye. Anyone opposed? No. The ayes have it, and we are adjourned, and thank you to the committee. We're out before 12 o'clock.